We're at the 2019 CROI. We're here with Adeel Butt, who's with the Weill Cornell Medical College in New York City, and we appreciate your taking the time away from the conference. We just completed a press conference, and I'm going to let you introduce your study that you presented at that press conference.
First of all, thank you for having me. So we looked at the incidence of diabetes in patients who were treated with antiviral agents for hepatitis C. So the background is that there is a clear association now between hepatitis C virus infection and diabetes mellitus. However, what is not clear is how treatment may affect future risk of diabetes. Now, there are some reports in literature that older treatments with pegylated interferon and ribavirin may actually precipitate or increase the risk of diabetes. But there are also more recent reports with the newer directly acting antiviral agents which indicate that they may mitigate the risk or reduce the incidence of diabetes and actually improve glycemic control.
So there's conflicting results.
But they're two different treatment regimens.
Okay, gotcha.
Right. So what is unknown, and no one has studied a direct comparison of untreated persons versus pegylated interferon ribavirin treated persons versus DAA treated persons. So what we wanted to look at was take all these three groups and see what is driving the risk of future diabetes, if anything is driving that risk.
And when you say future diabetes, that means it's not onset while you're in the treatment. It's any time in the future, and you're out how long? How long do you actually follow the patients?
Correct. So the first thing is that we excluded everyone who had prevalent diabetes at the start of the study.
I got you.
So we wanted to look at the future risk in people who do not have diabetes to start with and develop it after completion of treatment.
Okay.
So this was after 12 weeks of completion of treatment is when we started looking at the risk of diabetes. And the follow-up for the DAA treated group is about 5 years or so, because they're much newer drugs. But for those treated with PEG-RIBA is more than 10 years.
So that's pretty much where you'd either have it as a result of this other treatment or not?
So we parsed that out
yeah.
by looking at all the variables that may affect diabetes, for example, body mass index or age, because increasing age is also associated with the high risk. So, advanced liver disease is associated with the high risk of diabetes. So we adjust for all those variables so that we can look at independent effect of treatment as well as which treatment may be affecting that.
And you're comparing this with people who are not treated?
Correct. Untreated persons who are actually matched for demographics and other clinical variables.
To the best of your ability, and so forth. Yeah.
Yes.
So, and what's the number on the study? How many people?
So the total number is over 52,000 people,
Wow.
of which 26,000 were treated and 26,000 untreated controls. Within the 26,000 treated persons, about 4,700 and some were treated with PEG-RIBA, and a little over 21,000 were treated with a DAA regimen.
So was there just a single outcome, or was there other outcomes that you saw? Or is there any nested studies or anything that you were looking at beyond?
We looked at glycemic control in addition to incident diabetes. So there were three things we looked at. One is incidence rate of diabetes. Second is the risk of diabetes as in terms of hazards ratio. And the third was how does glucose control, how is the glucose control after a patient's complete treatment. But other than diabetes, we did not look at any outcome in this particular study. We have done other studies to look at other outcomes.
So what you take away from this study, do you have any ideas on where you need to go next? Is there other follow-on work that you need to do or questions that need to be answered?
I think one thing we need to understand is what is the mechanism of this improvement, that how do DAAs improve glycemic control or glucose control, and how do they decrease the incidence as well as the risk of future diabetes. I think understanding the mechanism would be really helpful. Beyond that, I think the take-home message is that we need to scale up treatment because there's still large pockets globally where people are not treated for Hep C. For whatever reason, there may be priority lists, for example, either because of costs or other reasons. So I think we need to tell them that there are benefits beyond the liver in terms of reducing the risk of diabetes. Our previous studies has shown a reduced risk of cardiovascular disease events. So there are multiple benefits of treatment with the new regimens.
Yeah, which would be preventative as well.
That is correct.
So what are where were the studies conducted? is it globally, or is it?
So the study was conducted in AccessHIV, which is the electronically retrieved cohort of Hep C infected veterans. So AccessHIV is a cohort of every veteran who has been diagnosed with Hep C in the US. And we have, for every Hep C infected person, we have an uninfected control. So the overall AccessHIV, which is a well-established cohort and has led to more than 35 high-impact papers so far, now has about close to 400,000 Hep C infected persons and close to 400,000 Hep C uninfected controls. So this is where we draw our patients from.
So, but you were suggesting that this would have implications around the world, and I think, I'm not sure what the pricing is around the world. I hope it's not as expensive. It certainly wouldn't be as expensive as it is in our USA, but it's still a very expensive drug.
In many developing countries, it's not expensive anymore because the pharmaceutical industry has had agreements with several governments. From what I've read in popular press, there are about 70 countries which have agreements with pharmaceutical industry to give cheap versions of the drugs. For example, in Egypt, India, Pakistan, there are very cheap versions. And in Pakistan, for example, the drug is given free by the government, and they have scaled up treatment to more than 100,000 patients in the first year because the drug is being given free of charge.
Right. And then they being aware of what your studies are, that there's outcomes beyond the actual specific reason you're taking the drug. So there's advantages to this, and there may be even more impetus to treat early.
This certainly is.
Yeah.
I think there's a very large growing body of evidence that there's so many benefits of treatment. So liver, of course, is the obvious one. Overall mortality is an obvious one. But beyond the liver, for example, cancers, extrahepatic cancers like lymphoma are reduced. Incidence of stroke in some reports is reduced. We have shown reduction in cardiovascular disease events, and in this meeting we presented data on diabetes. So taking this all together, I think it's a very compelling argument patients should be treated and treated early.
Well, thank you very much for presenting this information at the press conference, and then also for us too. I appreciate it very much.
My pleasure.
Thank you.
Thank you.